Welcome, everyone. Thank you for participating in this symposium on enhancing public health management on chemical incidents through collaboration with poison centers. My name is Michele Regimbald-Krnel, Director of the Environmental Health Science and Research Bureau of Health Canada, responsible for the Health Canada team, which supported the organization of this symposium. We are very pleased that our partners of the Global Health Security Initiative endorsed this event hosted by Canada. And I am inviting my Assistant Deputy Minister, Mr. Matt Jones, to say a few words to launch this symposium.
Welcome. Je m'appelle Matt Jones. I'm the Assistant Deputy Minister for the Healthy Environments and Consumer Safety Branch at Health Canada. As a public servant, my approach throughout my career has been to find meaningful work and give it everything you have. Preparing for chemical emergencies is meaningful work, and it's important that we do it well. So I'm glad so many people have been able to join this session and will be participating in these sessions over the next little while. I'm looking forward in particular to digging into some of the case studies and learning from the experiences of others. This work will be increasingly important as time goes by. Chemical emergencies have been happening more often than we would like, and it's more important than ever to be well prepared for quick and well-coordinated action. In Canada, emergency management and public health are a shared responsibility involving all levels of government. The Canadian Poison Centres and public health entities are two critical stakeholders in disaster management. In Canada, Health Canada, in partnership with Poison Centres, is leading the Canadian Surveillance System for Poison Information, CSPI, which is a core component of the Pan-Canadian Toxicovigilance Canada network, a system to foster collaboration between the poison centers and the public health authorities, regulatory agencies, and other stakeholders involved in public health management of chemical incidents and poisonings. Poison centers can play a lot of important roles. Improving early warnings and alerts by providing immediate notifications to public health authorities, providing expert consultation on medical management of patients that are exposed to chemicals, generating data to aid incident management and the development of effective responses, and facilitating timely, harmonized risk communication to the public. We look forward to exploring case studies from Asia, Europe, and North America, including major industrial accidents and poisoning events. These case studies will highlight the value of collaboration, as well as the lessons learned and challenges faced in protecting the health of impacted communities. Special thanks to the GHSI and CWIG Organizing Committee, including our Canadian colleagues at the National Collaborating Centre for Environmental Health, the Public Health Agency of Canada, Parachute, international partners, and the Canadian Poison Centres for their efforts in making this symposium possible. Enjoy the event, and thank you for your contributions.
Morning, afternoon, evening to all our speakers and delegates who've joined this symposium. My thanks to Michele, Reginald Kimball, and Assistant Deputy Minister Matthew Jones for kindly opening the symposium. I am Robie Kamanyire, and as co-chair of the Chemical Events Working Group of the Global Health Security Initiative, it gives me great pleasure to welcome you to this symposium on enhancing public health management of the chemical incidents through collaboration with poison centers. The Global Health Security Initiative is an informal network of countries and organizations that have come together to address global health security challenges. GHSI has contributed to improving global health security through coordination and collaboration with the World Health Organization and other institutions. GHSI provides a forum to generate knowledge, exchange information, and coordinate best practice within the health sector for confronting new threats and risks to global health. The aim is to improve preparedness through strengthened surveillance, detection, and response efforts. As we're aware, health security continues to evolve, and emerging challenges illustrate the need for improved preparedness and response strategies. The GHSI Chemical Events Working Group is focused on strengthening the preparedness, response, and recovery for chemical incidents, as well as risk prioritization of chemicals, the identification of research needs and best practices, including medical countermeasures, as well as dealing with other cross-hazard projects such as early alerting and reporting. The Chemical Events Working Group, supported by the United States, last hosted a virtual symposium in January 2022, focused on community recovery following a major chemical incident, which attracted participants from over 42 countries. This symposium aims to address the value of improved collaboration between poison centres and public health entities or agencies in the emergency management of chemical incidents. Unfortunately, we were due to have Leslie Onion, Head of Chemical Safety and Health Unit at WHO headquarters in Geneva, to provide us with a keynote address, but she's unable to join us today. We are planning to reschedule her presentation for next week. I will therefore lead on and highlight the objectives for today's symposium. Firstly, we aim to highlight the value of collaboration between poison centres and public health entities for the preparation and response to chemical incidents. Through the use of case studies to reflect on the benefits and challenges identified by the poison centres and public health teams during the response to a chemical incident. And finally, to share best practice or lessons and propose strategies to optimise collaboration between poison centres and public health agencies during chemical incidents. I'd therefore like to introduce Lydia Ma from the Canadian National Coordinating Centre for Environmental Health, who alongside the Chemical Emergency Management Team and Toxicovigilance Division of Health Canada are kindly hosting and coordinating this event on behalf of the Chemical Events Working Group. Lydia will explain the technology and logistics for the seminar.
Thank you, Robie. Hello, I'm Lydia Ma, and I'm delighted to bring greetings from the National Collaborating Centre for Environmental Health, or the NCCEH in short. The NCCH, your event host, is one of 6 national collaborating centres for public health in Canada. Our centre's focus is on environmental health, while others who are distributed across Canada, as you can see on the map, focus on Indigenous health, infectious diseases, methods and tools, healthy public policy, and determinants of health. To learn more about individual NCCs, please visit www.nccph.ca. Established in 2005 and funded by the Public Health Agency of Canada, the 6 NCCs specialize in knowledge translation. We have this mandate and orient our center's work in the following ways. We synthesize, translate, and exchange knowledge by incorporating evidence from scientific research and other knowledges to improve and strengthen public health practice, programs, and policy. We identify gaps in knowledge by catalyzing new research or the application of that research. And we build capacity by providing tools, establishing networks, foster collaborations and partnerships for Canada's public health system. Thank you to Michele, Regimbald-Krnel, and also our Assistant Deputy Minister of the Healthy Environments and Consumer Safety Branch, Health Canada, Matthew Jones, for delivering welcoming remarks. And as Robie already mentioned, we are unable to have Leslie Onion join us live today. However, we do plan to have her keynote opening remarks on day 2, which is happening next Thursday. Today, we have a stellar lineup of subject matter expert speakers from the Philippines, Oman, and Canada who will present their case studies. Our moderator today is Robie Kamanyire, Deputy Director for Chemicals, Toxicology, and Environmental Hazards at the UK Health Security Agency, who will introduce each of the speakers. For their bio sketches, please access them on infopoison.ca/events. And from there, you can visit the View More Information on Speakers link to view detailed bio sketches of each one of our speakers today, next Thursday as well. Today's agenda has been slightly modified due to Leslie's inability to join us. You can see on the screen that there is a scheduled break of 50 minutes between the first and second case studies. Each case will be followed immediately by a 10-minute question and answer, Q&A, with the case presenters. We do hope you will stay until today's adjournment. This agenda has been adjusted, as I mentioned, with an additional break inserted between case study number 2 and case study number 3. So that would be a time to allow us to have bio breaks. Schedules for days 2, February 13th, and 3, February 20th, are also available on the event website Again, that's www.infopoison.ca/events. I would like to mention a few logistics and to make some requests to our audience today. To enable us to improve on this offering, we would appreciate it if you can take time to give us your valued feedback. The evaluation survey is now open and will remain open until 11:59 p.m. Pacific Standard Time on February 20th. That will give sufficient time for those of you who will attend February 20th, day 3, to complete the survey. You can choose to do this, complete it after you have attended your last webinar, or fill it in as you go. To do so, there's a special instruction on the front page of the survey to help you keep your place and data in the survey. Thank you very much in advance for your opinions. You can go to the URL that's shown on the screen or point your mobile device to the QR code as shown. We will have this link in the chat, the Zoom chat, so you can always reach for it when you're ready for it. Here, we outline the event website once again. And my point also is to request that if you haven't registered for days 2 and 3, you can still do so. And you can refer your colleagues, interested other colleagues, to also join us in subsequent Thursdays. To answer a popular question, yes, presentation recordings will be made publicly available on the above website. However, there will be a short delay before you can see today's videos. We will post them as soon as they are made available. Thank you for your understanding. As you're already on our Zoom platform, you may have noticed that your video and audio functions are disabled. To communicate with our host team, please use the Zoom chat function. You will only be able to communicate with us, for example, with technical issues or general questions. You will not be able to communicate with others in the room, such as other participants. The Zoom closed captioning is enabled for participants. To turn it on, simply go to your Zoom toolbar, click on the arrow to the right of your closed caption button. You can also use this button to select the language that will be transcribed for you as captions. And for security reasons and to minimize disruptions, we as hosts will remove artificial intelligence meeting bots. Thank you for your understanding on that. A word about Slido. Upon entering the Zoom room, you would have been prompted to open your event Slido. If you had clicked it open, you're encouraged to use it to post content-related questions there. There is no Zoom Q&A function. For this reason, we wish to have all the questions parked in Slido, the event code being hashtag GHSI 2025. How Slido works is that if someone else had already asked your question, you can click on the upvote icon, which is a thumbs up, next to the question you want to see prioritized in the Q&A session. This will push the most upvoted questions to the top of the list for the moderator to present to speakers to address live. The more upvotes a question receives, the higher it will appear in the list of questions, and that indicates its importance to the audience and also an important consideration to be answered live during each Q&A session of 10 minutes, immediately preceding the case study. Note, though, if there's not enough time to answer questions during the day, there is another opportunity to address questions on Slido. On day 3, there will be a total of 80 minutes of Q&A time. This is a compelling reason for you to come back and not miss that very important and useful interactive session. Note also that you can choose to remain anonymous or to review your name when you ask your questions on Slido. A final note about Slido. It will be kept open from today, February 6th, until 15 minutes prior to the symposium adjournment on February 20th. That's day 3. This means that you can continue to access a Slido Q&A board to add your questions that may come up after you view the presentation recordings. And so now I will hand back the time to Robie. Thank you very much for your attention.
Many thanks, Lydia, for taking us through that. So it is time for the first case study. So I'd like to warmly welcome Dr. Irma Makalinao, Coordinator of CBRN Health Initiatives at the University of the Philippines, Manila, and Dr. April Llaneta, who is the Chair of the Department of Emergency Medicine at the University of the Philippines and Philippines General Hospital.
A pleasant day to all the participants of this virtual workshop. Thank you for this opportunity to make this presentation. This is entitled Harnessing the Power of Collaboration in the Ammonia Mass Casualty Incident of 2021 during the COVID-19 pandemic, and this will be shared between the experience of the UP National Poison Management and Control Center and the Emergency Department of the Philippine General Hospital. I have no known conflict of interest, and this particular presentation follows the principle of no attribution. Before I begin, let me first review the Western Pacific region, territories, and countries, and also highlight the areas where poison control centers are actually located. It's important to note because chemical incidents are actually public health concerns where they benefit from the collaboration with poison centers. We can see from this slide that there are actually 37 countries and territories that belong to the Western Pacific region. And of these, 9 poison centers actually exist in Australia, Cambodia, China, Japan, Malaysia, Mongolia, New Zealand, the Philippines, and Vietnam. In as far as 24/7 poison centers are concerned, all except for Japan and also in Mongolia, where 24/7 poison center service is not actually available. Let me highlight in this presentation the role of the UP National Poison Management and Control Center. So the UP National Poison Management and Control Centers began actually in 1975, first as an emergency room poison center where it is mostly collaborated by the Department of Family Medicine and also by the Department of Pediatrics, headed by the mother of Philippine toxicology, Professor Nelia P. Cortez Maramba. Subsequently, there was a project with the IDRC Canada and GTSET that allowed us to now name the Poison Center as the National Poison Control and Information Service, which was subsequently changed to the National Poison Management and Control Center by virtue of a board resolution of our Board of Regents. This particular poison center functions to serve the Filipino people in events of poisoning from acute poisoning and also chronic poisoning and other types of poisoning cases that we see in the Philippines. So as I've said, from NPCIS, it was changed to the UP National Poison Control Center, institutionalized by the Board of Regents in 2005. And this is actually linked to both the College of Medicine and the Philippine General Hospital, and also loosely attached to the Department of Pharmacology and Toxicology, where most of the initial laboratory tests such as RBC cholinesterase were actually being done. The main services of the UP NPMCC actually include treatment services, a poison information service, laboratory service, and of course, do a lot of linkage and services to other government agencies, including different kinds of organizations that deal with environment and health. So the highlight of the UP NPMCC training, of course, is the 2-year clinical toxicology fellowship program, which actually takes its roots from an initial clinical rotation at the Rocky Mountain Poison Center through the kindness of Dr. Richard Dart. We have also patterned some of our training for the Poison Information Specialist training to the Rocky Mountain Poison Center. We also allow clinical rotations of residents, students, and fellows of other types of specialization in the Philippine General Hospital and other hospitals. In the postgraduate courses, we have a lot of training courses also offered for nurses and also analytical toxicologists. We also had training courses for our administration for toxicology in the past. So in our research and development, we center, of course, on actual research that augment our knowledge in toxicology. We currently have a point of care testing that was approved by the Philippine General Hospital, and this will be on specific types of toxicants. And also we have a lot of work in line with toxicovigilance. As of 2024, and this is the latest service output of the UPNPMCC, we have seen so many patients and referred to us as telephone referrals, which is a change from our initial, when we were initially established. And so we now have more than 4,000 telephone referrals in contrast to what we had at the beginning in 1991 when the initial study was done. We still receive interdepartmental referrals, and as you can see in this slide, and we also at this point look at inpatient referrals and also outpatient referrals. In as far as the UPNPMCC is concerned, we also have a lot of social media presence. This is a way of actually promoting toxicovigilance. And as you can see, we have had advisories for pufferfish, and this has been posted and reposted by some people. And we have audiovisual presentations related to lead, caustic exposure, jellyfish sting, and the like. The UPNPMCC has been involved in chemical incident responses, and these are just some of the examples of responses that we have had in schools, like mercury spill, which actually required the US EPA team to assist in the cleanup operations, multiple chemical spill in a school laboratory generating about 1,855 kilograms of chemical waste, and of course, the one that really triggered a national disaster risk response with then President Arroyo was the Bohol poisoning incident, which was actually from contamination or the actual food poisoning that resulted from carbamate that was actually accidentally mixed with the food because of the cooking oil that was used. And this actually affected 144 children, causing the death of 27. So for today, the main focus is really the response of the UPNPMCC on the ammonia mass casualty incident. In this particular regard, we have seen that in the news clippings, there were a lot of information available about how many were hospitalized. The numbers actually do not match in some cases, but as far as deaths are concerned, they were consistent with 2 deaths recorded in this particular incident. What was actually important to see here is that if you look at this particular, you will see that there is actually a Google aerial map that shows the area where this particular event happened. And you can see the depopulated area, and this is the reason why in the television news report, you will see people running in different directions when the explosion actually happened. So this was how the timeline of the ammonia MCI actually happened in as far as the poison center is concerned. There was a report of the ammonia leak from an ice plant. There was news that actually broke out in several social media platforms. The UPNPMCC received a call from a local hospital inquiring about ammonia inhalation poisoning and the management of patients with such an exposure. Again, we can see here that there was a follow-up by the same hospital for dyspnea patient living near the ice plant, which became actually our index case. And then referring physician also reported they were expecting more patients due to the event. In as far as the subsequent action, minutes after this particular referral of the same hospital, toxicology fellow on duty alerted the on-call tox consultant about the incident. All the non-duty fellows were recalled to the poison center in anticipation of the surge of phone referrals. The NPMCC received a call from the same institution, this time referring 10 patients who were brought in due to difficulty of breathing, coughing, and burning eye pain. And then subsequently, the poison center recommended certain measures to alleviate the symptoms of these patients. After a few minutes, another hospital to the poison center for ammonia inhalants, and similarly, a protocol that was developed for this particular ammonia mass casualty incident contained recommendations that were actually relayed to the calling hospital, the hospital that was calling the poison center. So the NPMCC received another call, and this time this is from a citizen. So we are actually not only servicing hospitals, we have received calls actually from living in the nearby area, complaining of the pungent smell, and so the patient was advised to evacuate the area immediately. Actually, before we can actually make this recommendation, the Bureau of Fire Protection, who arrived at the scene, also recommended to the different citizenry of that area to either shelter in place or to move out of the area if they cannot shelter in place. Simultaneously, the other talks fellow was now talking to the BFP, the Bureau of Fire Protection First Responders, to really ask for more information about the actual ammonia leak. We were informed that the leak was actually plugged successfully, and therefore the leak actually was contained. NPMCC then informed the emergency room, and it's going to be discussed further by Dr. April Llaneta, because different types of measures they have taken in using the incident command system. So here you can see the slide that the code triage was actually activated, and resident physicians and departments were recalled in anticipation of patients. Simultaneously, there were patients who were arriving, and also at the same time, we have seen that the difficulty here was that at this point, we also had to triage patients with COVID-19. So in as far as the patients are concerned, we received 22 patients. There were other 50 patients found in the Navota City Hospital and 33 more in the Tondo General Hospital, which were the two main hospitals referring to the poison center at the time. Here in the particular admitted patients, you can see that there was a pediatric patient, and this was actually an infant who had to be intubated because of the very severe case of exposure to the ammonia inhalational injury. So in as far as UPN PMCC is concerned, we consider the successes to be in relation to, again, timely alert and notification, creation of a case-specific triage definition, and also a set of symptoms that allowed the other emergency rooms, not only the Philippine General Hospital, to have a uniform evaluation of patients, and they were triaged according to what will actually be explained later on by Dr. April Llaneta, and these were the green, the yellow, and also, of course, when you talk about the black one, and these are actually the mortalities. So you can see that it's very important to have effective coordination with relevant units and agencies. So what were the lessons that we actually learned? One, importance really of facilitated coordination and network with other agencies and poison centers. We coordinated with the Bureau of Fire Protection, the Health Emergency Management Bureau, the other poison centers such as Rizal Medical Center and East Avenue Medical Center. We had very good collaboration with Tondo General Hospital and the Navota City Hospital, along with the city health officers and the One Hospital Command Center, which was activated during the pandemic. What were the challenges? Of course, these were related to the limitations in the ability to admit more patients to PGH, since PGH was the tertiary referral hospital, admitting moderate to severe cases of COVID-19. And there was a need for rapid disposition of patients arising from the pandemic situation. What are the opportunities for improvement that we saw during this particular case? One is the specific decontamination protocol for infants and young children. We realized then that it was very important that we cannot actually decontaminate infants and young children in a similar manner to that of the adults, because such decontamination procedure, especially the wet decontamination, may result in hypothermia in infants and young children. So we also need to be able to clearly identify the role of public health in a pre-hospital response to a chemical incident, so that we will be able to at least stage the response within the vicinity or in the hold zone of an incident, and in the ambulance, and eventually in the hospital. So what can be a way forward for the UPN PMCC in chemical incidents? We need to train medical professionals, do simulation exercises with them, serve as a receiving hospital, and provide secondary decontamination if needed in other types of chemical incidents. Support the first responders through technical expertise, so they may actually communicating initially with the poison center by telephone. And of course, we need to conduct training and simulation exercises also for the personnel of PGH, along with other agencies and hospitals. So with that, I'd like to acknowledge the following who contributed to this presentation. And I'd also like to show you that we have actually created a guideline on chemical emergencies and hazardous material incident response, courtesy of the Department of Health's initiative and funded by the World Health Organization, Western Pacific Regional Office. Thank you very much.
Hello, everyone. I'm April Llaneta. I'm an emergency medicine specialist with the Department of Emergency Medicine, University of the Philippines College of Medicine, and the Philippine General Hospital. It is my honor to share with you a case study on managing a recent chemical incident in the Philippines. I have no relevant relationship or financial material support to disclose. On February 3, 2021, at 4:40 in the afternoon, an alert was received through the messaging group of the CBRN, or Chemical, Biological, Radiological, Nuclear Medical Response Team of the Philippine General Hospital, about a mass casualty incident in a nearby city involving an ammonia leak in an ice plant. The information was immediately passed on to the Chief Resident of the Department of Emergency Medicine, the Emergency Department Team Leader, and charge nurse on duty, as well as to the medical records section and the hospital security team. After verification of the information by the National Poison Management and Control Center, the mass casualty incident protocol of the hospital was activated and the emergency department team was mobilized. Since the hospital was a designated COVID-19 referral center, the ED staff had to quickly discuss and implement a revised setup in the emergency department that will facilitate the management of the patients exposed to ammonia while maintaining the areas for the COVID-19 patients. So the ED team designated areas for the ammonia exposed patients, the red zone for the critically ill, the yellow zone for the patients with moderate symptoms, and the green zone for those presenting with mild symptoms. An emergency mass decontamination area was set up outside of the ED by the CBRN team. 30 minutes later, while preparations for the arrival of the patients were still being laid out, the first batch of patients from the incident site arrived at the hospital. They were decontaminated and then sent to the ED. Since the ED was expecting more patients to arrive, the hospital incident command system was implemented. The incident command post was set up with the chair of the Department of Emergency Medicine as the incident commander. The second batch of patients arrived less than 30 minutes after the first batch. The incident commander, together with the National Poison Management and Control Center team, called a briefing within the next hour. Representatives from the different clinical departments and administrative and support services, such as the laboratory, pharmacy, and other units, were updated on the situation and were given specific tasks and responsibilities. Residents from the other specialty departments were assigned to handle patients in the 3-level category triage system. The toxicology team discussed the protocol to be followed for the categorization of the patients in terms of signs and symptoms and their management. Additional supplies and medications for the management of the patients were requested, which included oxygen tanks, oxygen regulators, nasal cannula face masks, and saline for eye irrigation. On the 4th hour from activation, 2 critical patients were transferred from a local hospital to the Philippine General Hospital. On the 6th hour, after confirming that the incident at the site has stabilized and that no more patients were expected to arrive, the incident commander recommended a de-escalation of the operations. 22 patients were seen, including 9 pediatric patients. Most were discharged from the emergency department improved. 1 was admitted to the intensive care unit and 3 to regular wards. The National Poison Management Control Center was able to receive, verify, and relay the initial information from the authorities to the ED team in a timely manner. This allowed the emergency department team to quickly activate the MCI protocol, or the mass casualty incident protocol of the hospital. The hospital CBRN team was able to immediately set up an emergency decontamination area outside of the ED with enough personnel to handle the decontamination of the patients who arrived in 2 batches. The hospital incident command system was implemented and was supported by good communication channels and responsive teams from the other clinical and support units. There was also good communication between the incident management team and the health authorities through established channels. The Poison Center team was able to develop and orient the response teams on the protocols for categorization and guidelines for the treatment of the patients exposed to the ammonia leak. And there was a good working relationship between the emergency department and the National Poison Management and Control teams. So what were the challenges in the incident response? The main challenge in managing this case was the ongoing COVID operations of the hospital, being one of the few designated COVID referral centers in Metro Manila. The ED staff had to quickly set up an emergency decontamination site outside the ED and rearrange the ED setup to accommodate patients exposed to the ammonia leak while continuing to provide emergency care to COVID patients. The second challenge was requesting additional personnel to augment the ED staff. Since the pandemic started, there were changes in the work shift and work schedule of the hospital staff. Fortunately, there was enough personnel recalled to help in the decontamination procedure and in the ED treatment areas. The administrative and other units of the hospital also provided support. So the opportunities for improvements include the need for continuous collaboration, which is already in place between the National Poison Management Control Center and the Emergency Department, especially when it comes to mass casualty incidents involving chemical agents. Good communication channels between hospital units and between the National Poison Management and Control Center and the government agencies and health authorities must be supported through updated coordination and response protocols and proper equipment and training of personnel. The implementation of the incident command system helped in providing a more efficient approach to these types of emergencies. The actual event gave the personnel an opportunity to practice the skills and knowledge about emergency management that have been taught to them during simulation exercises. Good clinical skills should go hand in hand with good emergency management skills for the provision of timely, accurate, and appropriate management to patients exposed to chemical and other hazards. Thus, all hospital personnel must undergo proper orientation on disaster and emergency management. Thank you very much for your attention.
Many thanks, Dr. Irma Makalinao and also Dr. April Llaneta. So just to encourage participants, please do post any questions you may have into the Slido so that we can put those to our speakers who've given a really good overview of both aspects of the response to this ammonia release in the Philippines. The question is, was the surge of non-duty tox fellows part of an already existing contingency plan or framework in the Philippines?
I think the question is directed to me because it talks about your question involves the tox fellows. Yes, actually, the hospital has a mechanism by which, depending upon the emergency or the expected number of patients, we actually can recall our the tox fellows who are actually not on duty. So this is something that we have done also, for example, during the holiday season, where we expect, for example, a lot of patients who would come in from, the firecracker injury and the like. We can actually recall hospital staff. And it's not only true for our tox fellows, it's actually something that the hospital has set up for many years now.
Okay. Thank you, Dr. Makalinao. The next question, which has been upvoted, is from Ziad Kazzi. What was the role of the Ministry of Health in this incident? Was this the CBRN team? Did the Ministry of Health contact the Poison Center?
I think the way I understood it was that whether the Ministry of Health contacted the Poison Center.
Yeah.
No, actually, it was not the Ministry of Health. For this particular ammonia case, it was actually a call from a specific hospital who actually were located near the incident site. And therefore, in anticipation of what might happen, they called the poison center. The good thing there was that there were actually previous experiences this particular hospital calling the poison center, and therefore it was not difficult for them to access our number and then refer patients to us. And in fact, what happened there was that the physician who was part of that hospital eventually became our toxicology fellow. So she decided to study toxicology more so that she can become the toxicologist also of that emergency room.
Great. Thank you very much. I'll just do the follow-on piece. So there was a secondary part to the question in terms of the role of the Ministry of Health in this incident, or the role of public health agencies in the incident. Were either actually involved. I think there was an interaction between the poison center and the hospital and the fire and rescue services, but it wasn't clear whether the Ministry of Health or the public health agencies were involved in helping with the response as well.
The role of the Department of Health was through the One Hospital Command. So that was the command center that was put in place for the COVID-19 response of the country. So it was the channels of that command center is also used for this particular incident.
Great, thank you very much, Dr.
And maybe to add to that, actually, so we have what we call a system of alert and notification, and that was already contained. Remember, at the end of my presentation, I showed this guidebook, and one of the chapters is actually alert and notification. So what the Poison Center did was we actually networked with the Health Emergency Management Bureau of the Department of Health, because they actually have a 24/7 operation center. They call it the OPSEN. And should it be necessary, this OPSEN can also contact other agencies to assist maybe on the ground, so that if there is a need to transport more patients, that will be possible. So we do that kind of coordination also as a poison center with the Health Emergency Management Bureau.
Great, thank you very much for that very clear answer. I think we've got another question from Peter Utov. How have your pediatric decontamination protocols changed since this incident?
Yeah, actually, so one of the things, as I'm actually a pediatrician as well. So when we had this case presented, because this was really a baby, less than 1 week old. And, there was a lot of problems in terms of respiratory. The difficulty of breathing was so pronounced that this baby was intubated almost immediately after the decontamination. I think one of the comments I made when we did have this case presented was, we have to be careful when we deal with infants. We usually should not separate the mother from the baby, because that will actually be more problematic, and that we should make sure that the temperature of the water that is being used is also tepid water rather than just the cold water coming directly, because we are really concerned about the hypothermia that might happen. So those are some of the things. And I think one issue is that there's really no specific protocol, which I think this is something that I have asked the Philippine Pediatric Society to work with us, so that, in a mass casualty incident, we may be able to have a very specific decontamination protocol for very young infants.
Thank you very much. I think a really key point there in terms of decontamination protocols, especially for the very, very young there. If we go to the next question that's been voted up, it follows on, was the ammonia algorithm chart communicated to all the hospitals nearby, or only to the ones that contacted the poison center?
So for the algorithm, so we have a network of poison centers, what we call them the DOH network of poison centers. So we anticipated that based on the location of the actual incident and the chance that they will have this particular poison centers nearer to them. So we communicated and shared the information early enough so that in case they will actually get patients, that they are already alerted before any patient would come. So I think that's the beauty of the fact that all of these people originated, in terms of training with the National Poison Center. So now that they're fielded by the Department of Health to the different areas of the country, then it's not difficult for them to also coordinate with us. But the two poison centers that we mentioned there, the East Avenue Medical Center and the Rizal Medical Center, are really within the same vicinity of the PGH in terms of they're all in Luzon. So or in the National Capital Region, which is also the area of the impact site.
Okay, great. Thank you. And then just to follow up on that one was, which method was used to share that protocol? Was it email, fax, or?
We actually use so we have Viber and the WhatsApp,
Okay.
so we can easily, transmit the protocol.
Yeah, great. Thank you. So would you be able to speak further to the partners involved in the coordination of public communication? So I think you touched on the fact that there was some information provided around sheltering in place. Was there any other risk communications to the wider community around either sheltering or evacuating during the incident?
So there was a consultant on duty during the time who was actually communicating with the first responder community. I also had the opportunity to speak to the Bureau of Fire Protection only because I have really worked with them in the past with actual chemical incidents and being on site to assist the first responder community. So one of the things I actually really asked them was that first, was they really able to now contain the leak? Because there was first an explosion and then there was a leak. So so they had time, they had to go back to the site, at least near the site, to do their own monitoring. Unfortunately, at that time, the real-time monitor that the Bureau of Fire Protection has was not working. So sometimes that's, when disaster strikes, that's when they don't work. And so in the end, you cannot also rely on the smell, I told them. So it's like we have to be able to give them tips that are not difficult when there's no measurement. But I think one of the important part there was, again, working with them in as far as trying to figure out whether we can now ask. So we said for the green patients, we want to move them out of our own hospital almost immediately because of the COVID-19. But we can't bring them back to the community if there's no assurance that, the levels are no longer something that will really cause more harm. So that communication part and risk assessment was something that we had to walk them through. And it was not only with the Bureau of Fire Protection, it was with the local government officials. So there was this communication also with the local government officials who were there trying to monitor the progress of that incident.
Okay, thank you, Dr. Makalinao. Then I think the next upvoted question is, are the decon procedures available for the public online? So can individuals who've joined this call access those decon procedures?
So for the Philippine General Hospital decon procedure, so we have it in our operations manual. It's not available though for others, but we can share it with. Usually, when we do collaborative conferences, we share those protocols.
Right, thank you. More questions.
And maybe
Sorry,
just to add to that, sorry. No, I just want to say that people might be wondering why we have those decontent. That the picture I showed you was actually something that was shared to me by Dr. Llaneta. Those were donated to us previously. I think it was in 2019 by the US Department of Defense Threat Reduction Agency. So we have some suits like the level A, B, and and C, and this particular decontent that we have acquired through the US Department of Defense. And we have also been using some of the training suits to train other agencies. And the most recent one was the request by the Army Surgeon General's office for some kind of training. So we brought that tent to their facility.
Right, thank you. The question is was there a need to decontaminate the individuals because they'd been exposed to a gas rather than a liquid?
There are two schools of thought really about gas, especially for those which are highly water soluble. Ammonia is an example of such a highly water soluble gas. So in this case, the decision to decontaminate was really because the patients came in with burning sensation on the skin. And therefore, it was not really the decon using the decon shower. It was mostly really using soap and water for 2 to 3 minutes just to remove the burning pain that was already on their skin. Of course, we were concerned also with the decon of the eyes was very important because we didn't want them to become blind after all. And so I think that's why I thought that at some point, we know that if we use water on ammonium hydroxide, because it becomes, I mean, ammonia will become ammonium hydroxide with water. But one of the things that was also important here is remember that this was a very crowded, impacted area, and the people were running, and so the sweating was there, and the sweat by itself has already dissolved some of the ammonia gas into ammonium hydroxide, which is really highly corrosive. And that's the reason why the decision to do some kind of improvised decontamination was actually performed.
Thank you very much. Really clear answer. There's the logic to that. The next question is, are there linkages with the emergency services? Would the poison center contact them when they identify a trend, either in patients presenting with a particular symptomatology?
So our poison center, the UP NPMCC, is open to any caller. So our number is publicized, and therefore, we also have social media presence, and therefore we can easily be contacted. We have been contacted by different kinds of emergency responders, even the general public. When there are some cases. So in this particular case of ammonia, we were contacted also by people in the community.
Yeah. I think what the question is also asking is that if the poison center identifies a trend in terms of patients presenting with a particular toxidrome, do you then directly link in with the emergency services, the EMS teams, to say we're seeing patients presenting with these types of symptoms? Is there an issue that they may be aware of?
Okay. Whether the poison center alerts them. Yeah, actually, we actually do that. So for example, I remember before during the time of the red tide poisoning, when we were seeing trends of people having, the symptomatology associated with red tide poisoning or saxitoxin poisoning, we actually alerted the community, the local government units who might be able so we create a case definition so that if you see these signs and symptoms, please bring these patients to the nearest hospital because it couldn't be always to the poison center, and consider the following emergency management. We have done that in the past. So similarly, when we had poisoning, so remember we had the school, I mentioned a school that had multiple chemical spill. We also did communicate with the local government unit, in fact, with the mayor directly of that community, so that we told them that these are the initial measures that you have to do. These are the types of symptomatology that you have to watch out for. And therefore, if these are present, it might be better to have that patient in a hospital rather than just remain in the community. So we have had different kinds of interventions. Many years that we have functioned as a poison center, we have also been part of different kinds of disasters in communities where we needed to transport patients, direct them to transport patients. We also do that as well.
Okay, thank you very much. The next highest one is, what lessons were learned from this incident and what could have been done differently if this reoccurred?
As somebody working in the emergency department, I think the timely sharing of information is one of the critical points. in responding to these types of emergencies. So I think that was clearly highlighted in this case. No? So there was good communication even before. No? We have established communications between the emergency department team, our own hospital EMS, emergency medical services team, our pre-hospital team, and health authorities. So that's crucial, as well as we have the protocol for mass casualty in place, and we can easily activate it. The key for us is to train our hospital personnel to respond. No? So we do a lot of simulation exercises, and I think that played a role in this response for this case.
Okay,
Anything you wish to add?
so in as far as the poison center is concerned, so I think it's important that in any chemical emergency, although this is the ammonia is the one that we're talking about, I think it's very important that the linkages, the ability to network and call the Bureau of Fire Protection, the environmental people, and the like, and the Department of Health should be established early, or the relationship should exist already, so that at any point where the emergency actually happens, it will be easy to, talk to them, call them, and ask for more information, or they can also call you. So I think that was something that we have established over the years, working with the different agencies like the Bureau of Fire Protection, which is really one of our major responder when it comes to a hazmat incident, or working with the police if there is really a need to do further investigation, and of course the security part of the police work in cordoning the area, or helping them, making sure that the first responders are actually safe. So these are things that we need to stop. The linkages and relationships must be there before the incident. So the continuous relationship with this public health and first responder community must be there.
I think we've come to the end. You've answered a lot of questions there. There are still more questions for us, but we're due to go to a break. So I can just express my sincere thanks to yourself, Professor Makalinao, and also Dr. Llaneta for such a fantastic presentation, and also addressing all these questions so well for us, especially since it must be very late for yourselves as well. So thank you very much for your contributions. It's much, much appreciated. And hopefully we will see you for the town hall session on the 20th of February to carry on the conversation around the incident and wider work within the WIPRO region. So thank you all very much indeed for the presentation. Without further ado, I'd like to welcome Dr. Ziad Kazzi, past president and co-director of Menatox, and also adjunct professor at the American University of Beirut and co-director of its clinical toxicology services. Dr. Badria Alhatali is also head of the Poison Control Section, Department of Environmental and Occupational Medicine for the Ministry of Oman. And finally, Dr. Mohamed Busafi is the Director of Emergency Management Center at the Ministry of Health in Oman, who are going to discuss the collaboration between Public Health Emergency Operations Center and their Poison Control Section in Oman as an example from EMRO. So colleagues, very welcome, and looking forward to your case study presentation. Thank you.
Hello, everyone. I'm here to present to you on the collaboration between the Public Health Emergency Operations Center and the Poison Control Section in Oman, an example from the Eastern Mediterranean Region Office countries of WHO. My name is Ziad Kazzi, and I have several hats and affiliations that I'm displaying on this slide, but most relevant to my presentation today, I am the past president and the co-director of the Middle East and North Africa Clinical Toxicology Association. I'm also an adjunct professor at the American University of Beirut and the co-director of its clinical toxicology services. I'd like to acknowledge, on behalf of myself and my co-presenters today, Dr. Hassan Al-Balushi, consultant in emergency medicine and medical toxicology in Sohar Hospital, who participated in preparing some of the materials that you will see today. I'm basing my part of the presentation today on a study that I conducted with colleagues from the region, including Dr. Badria Alhatali, Dr. Tharwat Zahran, and my emergency medicine resident in training, Dr. Kieran Christensen. In 2021 to 2022, where we surveyed the countries belonging to the EMRO region and surveyed their poison centers and asked them about their capabilities and capacities. So I'll be using the results of that study that's been published in the Journal of Medical Toxicology recently to inform my discussion with you today. Now, in this study, we surveyed the 22 countries listed under EMRO, and we reached out primarily to the director of the poison center when a poison center was easily identifiable. And there were some countries that did not have a poison center. So those were the 6 countries that we identified as lacking a poison center. Out of the 16 countries that we thought had poison centers, we were only able to interview 14 of these poison center directors or leaders. So we really had only 14 out of 16 poison centers interviewed. And we believe that EMRO countries, 16 out of them, out of 22, have a poison center. Now, of course, our study was conducted via a live interview that was recorded. We used Zoom, or we used Microsoft Teams, or we used WhatsApp in certain situations. The interviews were conducted in English or Arabic. In some cases, we spoke French and English to communicate with the interviewee. Of course, there are some limitations here based on our questions that we posed, the way our questions were understood and answered. And we did not have any opportunity to visit these centers in person. So when you look at the data that I'm presenting on this slide, I would like to really focus on the percent of all EMRO countries. I'm going to use that percentage. Of course, you can also look at the percent of countries with a poison center. But I want to focus on the percent out of these 22 countries that belong to EMRO. And you notice that 63% of countries in EMRO have a call center in a poison center, basically. And that's a good thing, I believe, as far as the percent, but not 100% like we want it to be, as defined by the WHO guidelines on poison centers that were recently published. Another important piece of information or important data is that only 40% of EMRO countries have a poison center that is open 24 hours a day, 7 days a week. And similarly, only 40% of EMRO countries have centers that take calls from the public and healthcare professionals. So that's something that's important to note here today when we consider the discussion that my colleagues will take on later on, and the rest of the regions present their case studies over the next 3 weeks. The WHO also indicates in its guidelines the importance of having a clinical toxicology treatment unit and a laboratory. And in our study, we found a low percentage of EMRO countries, 22% and 40%, that have a clinical toxicology treatment unit in their poison center and a laboratory, respectively. Now, this may not be conceived as essential in some parts of the world. For example, in the United States of America, where I practice at the Georgia Poison Center, we don't have a treatment unit inside of our poison center, although we are all clinically active and affiliated with a hospital where we see patients at the bedside with chemical exposures. So that specific data point is interesting and warrants discussion, whether the treatment unit should be in the poison center or whether an affiliation of the poison center toxicologist with a hospital would suffice. Similarly, for the laboratory as well, many poison centers, may not have a laboratory, but have an affiliation or have access to laboratory resources. Again, as you see in EMRO, only 40% have a laboratory within their structure. Another very important data point is that a very low percent of EMRO countries, 9%, report their data from their poison centers to the public. And I think that's important to consider considering the value of toxical surveillance data, reporting this data to the public, to other private and academic partners who can use this for research or for developing policies or advocacies and preventive strategies. Looking at the workforce that is employed at these poison centers in the EMRO countries, we find that you have 45% of them that have a clinical toxicologist. Typically, when we call a clinical toxicologist. In this specific survey, we specified a clinical pharmacologist with training in toxicology. And when you look at the medical toxicologists, who are physicians trained in medical toxicology, in that case, only 36% of EMRO countries have had such people on staff. Now, 50% of our poison centers and 50% of our countries at EMRO had information databases, which is very important. As we know, we need these information databases to look up specific chemicals and health effects and diagnostic recommendations for these exposures. 50% had an electronic medical record, and that's also important to capture the data in a reliable, uniform, analyzable manner. Very relevant to the theme of this webinar series, only 50% of EMRO countries' poison centers were involved in emergency preparedness. Again, this was very subjective. It was a question that we asked to our interviewees, and we did not really go into too much detail. So we have to just really take this data as is without the ability to drill down on more details on what is that involvement in emergency preparedness mean or entail. And I think today, when we hear from our colleagues in Oman, we'll hear more from their experience, and over the next 3 weeks, we'll learn from the rest of the world's experience in the role of a poison center in emergency preparedness, which is, I believe, very important. Along the similar line, poison centers in the EMRO region tend to know where antidotes are, but not necessarily stock them. So only 36% stock the antidotes or the antivenoms, which I believe is not surprising considering the resources required to stockpile antidotes and antivenoms. I believe knowing where these resources are as a poison center is sufficient. These poison centers in our region, 50% and 54% of them educate professionals and the public, and then perform functions in adverse drug reaction, vigilance, and research. So around 50% of them on average perform these functions. Finally, we gave a score to every poison center based on an arbitrary calculation that we devised based on the WHO guidelines for poison centers. And the reason why I show you this data, not to read every single category that we scored, I'd like you to just look at the graph below to see the spread in the scores. Some poison centers in our region scored on the higher side and others on the lower side, which really is, I believe, an accurate reflection of the heterogeneity of our poison centers in EMRO. Our poison centers have a variety of resources, level of resources, socioeconomic environments, political conflict environments that affect the capabilities and capacities of our poison centers. So it's not surprising to me to see the spread in the scores. But and to finish up today on a positive note, I believe this is an opportunity for our poison centers with higher scores to support our poison centers in our region with lower scores, and in a collaborative way, all of us together work towards a higher score benchmark for our region and the world. With that, I turn it over to my colleagues. This is my email if you'd like to reach out to me at a later point. And thank you for the opportunity.
So good morning, everyone, and sincere thanks and appreciation to the Global Health Security Initiative, Dr. Kazzi and his remarkable team for giving us in Oman this opportunity to speak about an experience that we are really proud about, and get the feedback and get the message delivered across the board. This will be about the chlorine release incident in Sahar, Oman, which is actually an overview of a successful emergency management and coordination. My name is Mohamed Busafi. I'm an emergency physician, board certified. I'm the director of Emergency and Public Health Response Center in Oman, in Ministry of Health, obviously in Oman. We're going to discuss about the timeline of the Public Health Emergency Operation Center activities. So the Public Health Emergency Operations Center was contacted by a clinician from Sohar Hospital Emergency Department. The incident was basically about a local and a regional plan activated as a result of this call. And we ended up in activating local and regional public health emergency sector as well. That included all the members in the sector. We also ended up in activating the National Hazmat Team. The Public Health Emergency Operations Center ended up in contacting the Oman Poison Control Center here in the Ministry of Health. The staff personal protective equipment and decontamination plan were discussed with the hospital staff, and the patients were actually redirected from Sohar Hospital to other hospitals, including those who were in the private sector, which is actually a success story that we can share here in this platform, in the sense that the private sector is actually a part of the national emergency response, which is actually something that we are really very proud in Oman. As a result of this large number of victims, which we will discuss obviously throughout this presentation, we had to distribute the patient to many other hospitals. One of the major advantages of being from a national committee and from a national emergency platform, that we had also the privilege to have a direct contact with the response team on the ground. So we were being connected with a command system at the scene. And luckily, actually, we were able to identify the exact type of chemical, which was the chlorine gas in this case. Following this incident, there were public communication and press release acknowledging also the Oman Poison Section role in managing this incident. And we actually got a lot of queries and a lot of interest from the public regarding the Poison Control Center and its roles. And we also highlighted the fact that we have around 8 board-certified consultants who were all trained abroad in the US. And now they are the one who are running the Poison Control Center. There were also an after-event monitoring, which was initiated in collaboration with the Poison Section in Sohar Hospital and the Public Health Emergency Operations Center and Emory University. In this slide, which I hope that you can see, we can just have a brief summary of the Emergency Operations Center roles in this incident. There are actually many things that we can talk about, but probably we can highlight this, that the activation and coordination of the response efforts, and also situation monitoring and real-time decision-making, resource management and allocation, which is a major element to be done in such scenarios, having proper communication. And we definitely know the impact of pitfalls in communication in these incidents. Incident command and emergency procedure were followed, and there was also liaison with the Poison Control Center and healthcare facilities in that government of North Al-Batana in Oman. There were also decision support and incident documentation locally at the center, at the Public Health Emergency Operations Center, and in liaison and in coordination with the Poison Control Center, and also post-incident recovery evaluation. And this was all integrated as a lesson to be learned for future preparedness for such incidents. In this slide, actually, I would like to highlight about the National Emergency Management Center, which is actually the platform which gathers different government and private health sectors constituting the Oman National Emergency Response System. So we have actually the analysis, risk and early warning, we have the search and rescue, we have the media and public information, we have the infrastructure sector, we have the hazmat materials sector, victim affairs, shelter and relief, and also media and public awareness. Maybe I forgot to mention that we are actually the medical and public health response. So the center, which is actually the Public Health Emergency Operations Center, is part of the medical response sector. This platform enables us all in Oman to work in integration and to complement each other's efforts. And during an emergency, we can utilize the resources that are otherwise available with armed forces or even with private sector. So this is actually something that we are really very proud in Oman and would like to share in this opportunity right now.
Hello, everyone. My name is Badria Alhatali. I'm the head of the Poison Control Section in the Department of Occupational and Environmental Health, National Center for Disease Control in the Ministry of Health. And I'm also a consultant emergency medicine and medical toxicologist at Royal Hospital in Oman. And currently I'm serving as the president of Minatox. And I would like to share how is the collaboration between the poison control section and the emergency response system that is basically give us a rapid response to this incident, and hence we were able to tackle many challenges that we faced during this, and also lessons that we learned from the incident and how we were able to basically overcome this for the future incidents. So again, because this happened in a hospital where actually one of our team from the medical toxicologists were there, so it was like a very rapid response. We got contacted initially from Sohar Hospital by this medical toxicologist, Dr. Hassan Al-Balushi, and then immediately after we get notified by the EOC that we are actually dealing with an incident of some sort of gas that has been released in the industrial area, which is about 500 meters away from the hospital. And we were able to rely on the signs and symptoms that these patients presented with to rapidly identify what could be the possibilities of this kind of an exposure. Although that, this call was started at around 9:15 p.m., which is unfortunately our system currently, because of the initial development of the poisoning center, the service closed around 9:30. However, we were able to handle this directly afterward, and it was, we were able to record all the cases along as the signs and symptoms, as well as the management plan later on. And we were able to collaborate with the public health emergency response team in terms of what is the appropriate PPEs and ways of decontamination, although we struggled with the decontamination considering the number of victims that was being involved. And we were able to basically from the poison center to follow up these cases later on and find out how their course of illness and what is the consequences. And constantly we were getting consultations from the healthcare professionals in Sohar Hospital at the different levels, basically asking about the further management of such cases. So we had about 42 cases that's been involved. However, only 31 that came directly to Sohar Hospital. Majority of them were Bangladesh, considering that this is happened in a specific industrial area. And it was a majority of them were young, so they were between 20 to 30 years of age. And we could, face later on the challenges, particularly in certain group because of the high incidence of, past medical history of being smokers. Now, as an irritant gas, which is chlorine, the expected symptoms that we also, as a poisoning center, we were able to predict and tell the physicians basically to monitor and watch. Mainly there were a cough, shortness of breath, and some irritation in the upper airway. We were also able to help in terms of the disposition of these patients, so the majority of the cases that got sent home with a follow-up later on from the center, we had only one case that got admitted to the intensive care due to a past medical history of asthma. And then, of course, later on, we were able to do this kind of follow-up over 48 hours and then 2 weeks from the incidents to see what is the residual symptoms and what extra things that can be done for these cases, considering the possibility of developing interstitial lung diseases and so on. So I guess when it comes to the success in this scenario, we can look at, the fundamental of this kind of collaboration between the agent, host, and the environment. And so we were, although this is a chlorine gas, which have an intermediate water solubility as a chemical, we were not sure what we are dealing with at the beginning. And also it is a rapid onset of symptoms that basically tackled we required immediate address to it. In terms of the environment, we were lucky that this happened in an open space. So, and then we were able to basically estimate the amount later on with the help of the EOC and their team, basically. And it was about 500 meters away from a residency area. So that's probably the reason why we saw this kind or this number of victims. Now, the host, the actually majority of them were healthy workers. Unfortunately, none of them were wearing PPE at that time. Of course, it was the mid of the night. Almost people were resting in their homes when all of this happened. Now, it also had this, the advantage of having a local physician as a clinical toxicologist that happened to be there in the shift during this incident, basically facilitated lots of, kind of like approach to these cases, as well as the further management of them. Now, the prompt contact with the public health EOC was a success as well. And it basically, it helped this kind of quick collaboration with the Oman Poisoning Center, basically to be able to tackle the cases and get a proper management in a timely manner. The pre-existing contacts between the three players here, the public health EOC, the Sahar Hospital and the Poisoning Center, were able to basically, optimize the response. And of course, the clinical management was redirected rapidly by the clinical toxicology team to optimize the resources utilization. And we were able to test the public health EOC plans for such surge or such chemical incidents. Now, of course, the challenges that we faced is that we don't have currently a service that is running 24/7. And so probably, handling these cases later on, this is into a smaller stage. But if we consider quite a bigger incident, then maybe that would be a challenge for us. Incident management system in an electronic way, the decontamination setup, and the hustling, basically, finding the appropriate place for them for decontamination. However, the emergency preparedness plan was basically tested at that point, and we were able to find out what is the plan B that the hospital has. And of course, one of the things that always is there in any kind of incident is that the emergency physicians at the beginning, or the first responders, they're not sure what is going on. And so they're basically having this kind of not knowing exactly what they are facing and how to manage, probably was a major challenge. There are multiple solutions that probably could have been, addressed in a different way. And definitely that is something that is an aftermath is being, consider the integration between the poisoning center, enforcing this kind of collaboration, sharing resources among us. And of course, training and exercises is always the mainstay of, response to such cases, collaborating with the industrial sector. Although this is like an antidote which is not required, apart from oxygen and a little bit of standardized plan of management, but stockpiling was one of the things that has been addressed after this incident, looking into what is available and what we should have. And eventually enhancing the role of poisoning centers in communicating the risk and providing clinical guidance for the healthcare professionals as well as to the public.
Thank you very much indeed, Dr. Alhatali. Really impressive presentation there, alongside Dr. Busafi and Dr. Kazzi as well. And it looks like we are getting lots of questions straight into the chat. I believe, unfortunately, Dr. Busafi is unable to join us due to a clash, but hopefully both of you will be able to pick up the questions, or we'll reserve some for him for the 20th as well. So I think if we kick off first with the highest ranked question, considering most poison centres do collect data in some form, do you think the low percentage of poison centres which report to the public could be improved by annual reports as per the WHO guidance, which encourages this?
I think it's very important in terms of the awareness of the most exposures that we are facing in the poisoning center, that the public need to be aware about. And at the same time, it is, if you think about the work of the the poisoning centers, is actually more of a collaboration as well. So you have to have that transparency with the public. And so in order to reach into that, you need to have kind of like an annual report that gets submitted, as it is being standardized by the WHO and other agencies as well, that they do that in a regular basis.
Right.
And I would add to that, Robie, that I would add to that we as an organization, the GHSI or WHO, or specialty organizations like MENA Talks, can raise awareness about the importance of these reports, and then remove any concerns or alleviate any concerns from our governments about the security of this data or the sensitivity of this data, how it can be presented in a de-identified way that meets their requirement.
Yeah, great.
Yeah.
Thank you. Very good. Next question is from Richard Wootton. First, he says it's very impressive, but he's interested in learning more about how the Poison Centre is integrated into the Public Health Emergency Operations Centre. Would the Poison Centre be able to work with the Public Health Emergency Operations Centre partners and the National Emergency Management Centre to push timely public communications, in this instance to cell phones in proximity, but I guess to the local population as well?
So, considering this scenario specifically, we have a very good collaboration when it comes to between the public health emergency response and our center, the CDC center, and then the poisoning section, as well as the other agents in the country. And and I don't know if you know Oman, but it's relatively a small country, so we are so connected to each other. And so we have this kind of system where we get involved ahead of time, and then we can evaluate and see whether we have a role in that or not. So even if there is nothing there in the plan by itself, sometimes you get a text or you get a call and say, okay, I'm facing this. Do you think that there is anything that you can add into it, and so on? So this kind of collaboration between all of us made it a bit more easier, to handle such events.
Great, thank you.
Robie, if I may add to that, from an EMRO perspective, EMRO countries, the EMRO countries are somewhat interesting because their poison centers are fully integrated in the governmental structure, right? And that's a good thing. But at the same time, that occasionally provides a specific, preconceived notion of that poison center as either working in forensic or either working in emergency management or not. I think the nature of a poison center is that it's so versatile. It has an emergency management function, but that doesn't really define it only. There are other things that a poison center does in forensic, in prevention, in pure public health preventive strategies, toxicovigilance, toxicosurveillance, okay? And that's a challenge for us. How do we really defend the poison center's versatile identity, allow it to interact with various sectors within a government structure that may or may not allow that? And I think there's a lot of work to be done in that in the future.
I guess one of the challenges around that as well is managing demand, because when you're seen as being valuable, you can get a lot of demand from different actors as well, asking for support as well. So
it'd be a good thing. Demand is a good thing. It means that they know about you and they need you.
Yeah, great. If we move on then, is there, I think this is probably more for you, Dr. Kazzi, is there an agreement or an existing MOU between different EMRO countries for the procurement or quick access to antidotes in the case of national disaster emergencies?
I think Badria and I, we've been in situations where, we had to really rely heavily on phone calls, WHO supporting us, regional office supporting us and trying to get some specific antidotes or antitoxins. That's a great idea. I think that's a project that, would be important, will make a difference.
Yeah.
All of us.
Yeah, although we have currently we have the Gulf CDC, and it's basically that is is the collaboration between the Gulf countries. So which is we have that kind of connection among us.
Right, thank you. Next question. I think this is in relation to Dr. Kazzi's presentation. So Corinne says, we tried a similar approach to the survey in Africa, but unfortunately the data was skewed. The surveys often have their limitations. Ideally, following up your survey with an in-depth qualitative interviews with directors would provide richer insights. How feasible do you think this would be in your region?
I think that's a great idea, Karen. And I actually had that in the recommendations of our paper. We talk about that. And happy to talk to you about this. I know Kareem's going to be with us in MENA Talks in a couple of weeks. And we invite everybody to join us February 23 to 26 in Oman. But I think one thing to do is, one of the things that we propose in the paper, and we discussed, Badria and I, is a benchmarking initiative, a mentoring initiative, where, say, for example, an entity would offer a service to our poison centers to kind of like, do an in-person visit, properly assess qualitatively all these capabilities and capacity, followed by a plan to benchmark, and then push the benchmark higher with proper follow-up and mentoring or support. I think we do that in hospitals, right? I mean, in healthcare systems, they do these accreditations or these type of like process improvement plans.
Yeah.
I think WHO, again, we ask so much from WHO, but WHO, the global community, specialty organizations, healthcare systems in the region can potentially embark in this project with the support and, of course, consent of the government to allow all of this.
Right. Thank you for that. Anything to add, Dr. Alhatali?
No, I think I echo what Kazzi said. It's quite challenging considering the the diversity in the way how the poisoning centers set up in different EMRO region. And so it would be quite challenging basically to get into the concept of standardizing what kind of service that it should be provided. However, that I think that MENA Talks is looking forward to it being an association in the region, and then we are encouraging all of the poisoning centers to be part within it, and so in that way we have this kind of like arrangement can be easily done.
And I want to just mention here, Robie, that there's an Eastern Mediterranean Poison Center Network, EMPC, that was created with support from WHO several years ago. So, and MENA Talks, collaborates with EMPCN. Currently, there's some like inactivity ongoing due to a variety of reasons. But that's another group that is valuable that we could leverage and work with.
Yeah. Interestingly, following on, it's not top ranked, but there's a question there from Mark Winter about the closure at 21:30 and whether it's feasible to share calls from the public answered by other EMRO countries. I don't know if you can see, I think it's a bit of a challenge.
It's quite a challenge. It's again, if we don't have that MOU of collaboration between us, and then it is like every poison center has its own identity, whether it is governmental or private, in a private sector, and so reaching into that level is quite challenging. Although we tried it, so we had some sort of like informal collaboration with different countries, like for example Qatar, and then we did that for Abu Dhabi. But it is there. It just need to basically we do more efforts and we step in and we say that this is required, because if we look at it, it is quite hard, sometimes with different resources, from one country to another, it might be very difficult to reach to that optimal kind of standardized poisoning center level. And certainly we can collaborate to overcome this.
Remember, Robie, the heterogeneity of our region.
Yes. Yeah.
The Gulf CDC or the GCC group is probably the best case scenario for this, such an initiative.
Yeah.
But beyond that, it gets complex. We have different languages as well. Remember that.
Yeah. No, thank you. And then is the one from Sharika, is the poison center surveillance system linked to your Ministry of Health's notification reporting system for accidental poisoning?
Yes. For us, yes. For Oman, we have that. We have a separate notification system that is, we have to report all the poisoning cases through that. We're trying our best, to basically encourage everybody, also for if they are not calling the poison call center, they can basically notify the cases by themselves through our data entry system in the Ministry of Health hospitals, at least. So we have that system is implemented, yes.
Okay, I think it was part of your lessons learned as well about the incident management system and having access to that. I don't know, is it integrated at all, or do you have the ability to share between the different incident management systems between the poison center and also the main national emergency center as well?
Yeah, we don't have that instant connection, I would say, when it comes to the electronic database, but we share the reports between each other. But in a like immediate 24/7, I would say it is not still there. It is in the our poison control section is actually still in the development phase. So there are many challenges and many things that had to be added on into the system.
Great, thank you very much. And then the next one is there is there a mechanism by which industrials and companies can share the list of all the chemical components that they're dealing with on site with the poison centers, so that you're better prepared and able to share information or make sure that antidotes are available or information is available for the public?
So if I'm speaking about Oman, the beauty of being part of the occupational and environmental health department, and we have the one who's responsible for the chemical management here is the environmental authority, which we have a direct contact with them. So all kind of chemicals has to be registered through that, and we get the list. So eventually, if we needed to know, for example, what sort of chemicals that is banned, what sort of chemicals that they can, use in the industrial level or at individual levels, we get that kind of list, and accordingly we act. And we also have the ability to communicate with them as well if there is an incident of any kind of chemical that is, so there are some sort of occasionally we get cases that get exposed to a certain chemical that is not supposed to be in the country, So we need to notify them ahead of time about that. And we had lots of collaboration in that matter. Great,
thank you very much.
And Robie, taking out of Oman, if it's okay, go to Lebanon, for example, and the Beirut port explosion is a flagrant example of lack of knowledge and chemical security failure. And you can find that in many of the Emirate countries, unfortunately. The other thing that you want to think about is the responders, the first responders, their knowledge of what chemicals they are facing. And unfortunately, that's difficult. National chemical mapping projects, are not present in every country, unfortunately, in Emerald. And I hope it should be. Thank you.
Right. Really good point. Thank you. And then next question. What was the main communication tool to the residents or the evacuated people? Was it sort of WhatsApp, phones, local media, TV channels? And then did the message also include a what to do in case of evacuation? Is that something that the Poison Centre in Oman provides or supports other agencies to provide?
So for the current system that we don't have the privilege to do that. Although once they get registered in the hospital, we get their contacts. And so we were able to follow them by phone. So, we call them and we get the follow-up. It was around 48 hours after the incident. And then later on, we call them to come to the hospital 2 weeks later, basically for general checkup. Now, the announcement was through the Ministry of Health media. So there were different, communication methods that happened through this. We also communicated with their managers, like, on-site managers, basically to distribute certain information that is required for them to know.
It's important to remember, Robie, in this incident, and Badria, you can elaborate, that the majority of the victims were the workers that were living on the site. It was like a dormitory or residence for workers, correct, Badria?
Yeah, that's true. Yeah. And so it was very easy,
basically,
to directly, so it was like a small cohort in a very specific place that we were able to communicate with them very easily. Yeah.
Badria showed us briefly, Robie, but we conducted long-term follow-up, which I think is unique and often not thought of. A Poison Center playing a role in looking for the after-event monitoring of the exposed population, looking for the potential for non-occupational asthma, reactive airway dysfunction syndrome in these victims, and that was important.
Yeah, and I think that's the key thing is participating in that recovery effort after the incident as well, gathering really useful information. One question for me, I think it suggested that the site was 500 meters from residential areas, but also suggested it was about 500 meters from the hospital as well, or did I get that wrong?
Maybe it was maybe it was a mistake during the call. The hospital is about 500 meters from the residency area. Okay, so it is about 500 meters to the residency area and then 500 meters to the hospital.
I was just thinking about potential impacts from the site to the hospital itself.
To the hospital as well. Yeah, exactly. You're right.
No, fantastic. Thank you very much for a really great presentation and taking the time to answer the questions as well. As noted before, we will start capturing those that we haven't had a chance to answer and hopefully pick those up at the event on the 20th of February as well. So really lots of virtual clapping for yourself and Dr. Alhatali and Dr. Kazzi, and also for Dr. Busafi for your excellent input for the session. It is much appreciated. Colleagues, welcome back to the final case study for today. Gives me pleasure to introduce our colleagues from Canada, JinHee Kim, who's a public health physician from the Environmental and Occupational Health for Public Health Ontario, David McVea, public health physician, Environmental and Occupational Health, Public Health Ontario, and Emily Austin, who's a toxicologist from the Ontario Poison Centre, and finally Richard Wootton, who's the team lead of Health Canada's Surveillance and Analytics section within the Chemical Emergency Management and Toxicovigilance Division of Health Canada. So colleagues, thank you very much. I look forward to your presentation on an aconite outbreak.
Hi, thanks very much to everybody who's listening today. We are excited to present as a group about the Aconite outbreak events of 2022. The management and lessons learned from Canada. Each of our speakers will introduce themselves as they go. And I'm first up. My name is Emily Austin, and I'm the medical director at the Ontario Poison Centre. None of us have any conflicts of interest to declare or share today. So just to sort of set the stage for some of the events that we're going to speak about today, here in Canada, there are 5 poison centres that provide poison centre services to the population of Canada. I'm here speaking from the Ontario Poison Centre, which is funded to provide poison centre services to our province of Ontario, Manitoba, as well as the territory of Nunavut. And the other poison centre that we're going to hear from today is the British Columbia Drug and Poison Information Centre. And BC's Poison Centre is funded to cover British Columbia, as well as the Yukon Territory. Poison centers can have multiple different structures and activities, and I'll speak a little bit about the Ontario Poison Center and who we are. The main activity of the Ontario Poison Center is our 24-hour-a-day, 7 days a week telephone toxicology consult service, where members of the public or healthcare providers can call us and will reach one of our team members, which would be usually a nurse or a pharmacist who is a specialist in poison information and who is supported by a physician on call who has expertise in medical toxicology. And when we take these calls, we manage on a case-by-case basis the individual's poisoning exposure to help provide them with support and management advice. We try to tailor our treatment recommendations that are specific to the caller, as opposed to having sort of a one-fits-all approach, for example, to, let's say, a caustic exposure or something like that. We actually deal with exactly what that caller is speaking about. And in addition to this, we make a real effort to provide evidence-based and up-to-date recommendations. And you can imagine how important this is when you're dealing with healthcare providers at the bedside who are caring for some potentially very sick poisoned patients. I'll speak now a little bit about some of the other activities that the Poison Center, specifically Ontario, is involved in. We participate in some toxicovigilance and toxicosurveillance initiatives currently being led through the Public Health Agency of Canada and the Toxicovigilance Canada initiative. In addition, we're very committed to supporting healthcare provider education as it pertains to toxicology and poisonings. We have a strong education system for training medical learners, as well as supporting nurses who may be going and working in more remote and rural areas in the management and diagnosis of poison patients. We try to contribute to advancing knowledge in medical toxicology and contributing to the medical literature and the research area or research in this field. And finally, we participate in public outreach and education as it pertains to poisoning and poison prevention.
Thanks very much. So my name is Dr. David McVea, and I'm a public health physician at the BC Centre for Disease Control, which is where the Drug and Poison Center, the Drug and Poison Information Center for BC is located. And I wanted to keep this slide very similar to the one that you just saw about Ontario, because the work that DPIC does is very similar. We receive calls, about 30,000 calls from BC and the Yukon from the public, as well as from emergency rooms and primary care clinics. We provide outreach, education, and surveillance also. But one key difference, and you'll hear more about this throughout our presentation today, is that within BC, the Drug and Poison Information Center, the Provincial Poison Center, is located within the BC CDC, which is a key provincial public health agency. So that location within public health makes for some excellent opportunities for surveillance and for collaboration, as you'll see hopefully throughout this presentation today. So for a bit of other context about how public health and clinical services are delivered in the province of British Columbia, I have a map just on the left-hand side there showing you the province of British Columbia, and it's divided into 5 regional health authorities. And these provide local public health services as well as publicly funded clinical care. And then the British Columbia Centre for Disease Control is a provincial agency that provides support, technical expertise, guidance on more complex issues, as well as working on issues that involve or span multiple health authorities or the entire province. And so the BC Drug and Poison Information Center is located where I work within the BC Centre for Disease Control, Environmental Health Services. All right, so I'd like to begin now by talking to you about the case study that we're going to be presenting. So in British Columbia in 2022, in February, I'll show you a more detailed timeline in a moment. 2 people presented to an emergency department at one of the hospitals in the Metro Vancouver area. They were seeking care for symptoms that began soon after they ate a home-cooked chicken meal. This was chicken that was prepared at home with recently purchased, locally purchased sand ginger. Within 2 hours of consuming this chicken, the people experienced numbness around their mouth, vomiting, lightheadedness, and some cardiac symptoms. And on presenting to the emergency room, it was confirmed they had some cardiac irregularities. So the emergency department physicians in British Columbia, they have a great relationship with DPIC, and they called quickly to speak to them for management advice. And the DPIC staff who were receiving calls that evening recognized that the symptoms were likely due to aconitine poisoning. based on the symptoms and the fact that this had been prepared using a powdered spice, and the symptoms were very rapid onset, or relatively rapid onset after consuming the chicken. So a little bit now about aconitum and aconitine, which is the subject of this discussion here. So aconitum species, this is a genus of herbaceous plants, and they include species that people may more commonly know as monkshood or wolfsbane. These are very highly toxic plants due to aconitine and related alkaloids. And these are compounds that interfere with, they block voltage-sensitive sodium channels. So their main mechanism of action is through neuro and cardiotoxicity, through paralysis and through cardiac arrhythmias. And they can be used in traditional medicines after boiling or soaking to reduce the toxins, but the index between a very dangerous dose and a therapeutic dose is really quite narrow. Off to the right-hand side there, you can see an image that shows some of the fresh roots on the left-hand side and then some of the dried roots on the right-hand side. So now a bit of a discussion about the BC public health investigation. So building off of that close relationship between public health and poison control in British Columbia, the Drug and Poison Information Center immediately notified the Regional Health Authority in which this occurred, as well as the BC CDC food safety and environmental health teams. And as I mentioned, that's where I work in the environmental health teams, and the food safety team is part of that. And it's a very close relationship. We're literally down the hall from each other. Because this was a fairly small cluster of cases within a single health authority, the investigation was led by that regional health authority. So they inspected the retail outlet and they ensured that the implicated spices were held and were not further distributed or sold. The product was traced back to an Ontario distributor. However, the product had been prepared and repackaged within the retail outlet, which led to some difficulties in totally tracing it back with a definitive traceback. Testing for, as I mentioned earlier, the initial suspicion for aconitine was based on the presentation and the route of exposure, but the testing to confirm that was a bit of a challenge and ultimately is performed by an academic partner. And this again was part of the shows some of the benefit of having an academic or a technical institute partnered with the DPIC, because we had some of those technical and academic connections that could support the testing for this relatively unusual exposure and toxin. And then once that identification was confirmed, public notice was issued jointly by BC CDC and by the Regional Health Authority with mention and support of the Drug and Poison Information Center, of course. And a key point is that staff from the Poison Center, from DPIC, were present and active throughout. They were attending and joining all of our meetings. They were providing really important technical information about this toxin, about what the symptoms, how they present, how others might be affected, and so on. So that relationship made its way all the way through this investigation. CFIA, the Canadian Food Inspection Agency, they were notified. They were involved in an important partner. But at their level, the federal level, their actions were limited because no test was available for this relatively, as I mentioned, relatively unusual toxin. The product was prepared and repackaged at a retail outlet, so making that decisive, definitive traceback was difficult, and a larger recall was not possible. So here's a timeline that shows a little bit of the details. On the left-hand side there, you see where the cases attended the emergency room on February 4th. And immediately after that was around midnight, actually quite late in the day. The next morning early, the Poison Control Center notified the medical health officer at the relevant Regional Health Authority, as well as BC Centre for Disease Control. And then as you move your way through the timeline there, you can see some delays. And I talked about some of those causes due to difficulties in knowing which product definitively was involved, difficulties in having it tested for, some difficulties around record keeping, both at the retail and within the initial patient contact. None of those delays, though, were related to anything to do with the relationship between poison control and public health. That went very smoothly throughout this entire investigation. So I'll talk now about some of the successes and opportunities, specifically within the context of British Columbia. We're going to have some presenters at the end. Some of our colleagues are going to talk a bit more broadly about the Canadian context. So I've described to you some of the strong connections between poison control and public health, and they really provided rapid notification to public health, access to the clinical records that were necessary, that were within the Drug and Poison Information Center, and some really strong and helpful toxicological expertise. And then great, strong working relationships between BCCDC and the Regional Health Authority facilitated collaboration and access to academic partners. And I will note also that DPIC has, the Drug and Poison Center, has strong direct connections to the Regional Health Authority also. So they can contact them, the medical health officers or the environmental health officers, directly as needed, and they often do. A couple of the things that we noted through this is that BCCDC, we've clarified the roles and actions during toxic foodborne incidences. Like many jurisdictions, we have a protocol for foodborne outbreak illnesses, but as we discovered as this unfolded, it didn't really envision toxic exposures, and so that wasn't very well laid out. So we've taken the opportunity to revisit that plan, and one of the things that we've done is we have built in explicitly a role for the Drug and Poison Information Center. We all collaborated implicitly beforehand, but it's now very explicit in our foodborne illness outbreak protocol. And then we note that confirmatory testing for unusual toxins certainly will remain a challenge, but the partnership between the Drug and Poison Information Center, BCCDC, and academic partners was really very helpful in making those, making that definitive test result in this case, and we'll be able to build off of that in the future as needed. And with that, I'll pass it off to my colleague, Dr. Kim, for the Ontario context.
Thanks very much, David. My name is JinHee Kim. I'm the physician lead for environmental and occupational health at Public Health Ontario. And there are a few contrasts between what our colleagues in BC have as part of their system and Ontario. So I wanted to start with a small kind of a context note. You see Ontario there in red in the figure on the top right-hand corner. That's where we are. And in Ontario's context, healthcare and public health are publicly funded, but distinct systems. The healthcare system provides clinical care, and public health services are provided by what are called public health units, which are regional or locally based. And there are 29 public health units in Ontario. And of note, the Ontario Poison Center is embedded within more so within the clinical care system based out of a hospital. In addition, the government's Ministry of Health and the Chief Medical Officer of Health provides for public health policy and standards. And Public Health Ontario, which is where I'm based, is a scientific and technical agency that provides support to the government and the public health units primarily. So there is interaction, even though we are separate systems, there is interaction between the healthcare and the public health systems, with some key examples being reportable diseases. Clinical cases of heavy metal exposures are often common reasons for public health referral from clinicians. And as well, this Aconite cluster that will continue the thread on with the Ontario story, the cluster of unusual illnesses of environmental cause, those can also be referred to public health as well. So in Ontario, you'll recall that the BC incident happened in February. That same year, a local public health unit became aware of a cluster in August of 2022. The previous evening on August 28th, 12 people had been sent to hospital after dining at a restaurant, with 5 of those individuals eventually needing intensive care. And within what they described was that within 1 hour of dining, there was numbness of the tongue, which was the most common symptom, as well as paresthesias, nausea, vomiting, reduced consciousness, and elevated heart rate. The clinicians involved did consult Ontario Poison Center. And when the public health unit started investigating, they quickly focused their attention on a specialty chicken dish And the story there was that the restaurant had run out of spice, and they ran out and purchased some prepackaged galenga or sand ginger powder from a local supermarket, which actually looked different from the usual spice they used. And when they used it in this dish, of course, there was fairly quickly customer complaints at the restaurant, followed by symptoms with an apparent dose response according to how much of the chicken dish that the people consumed. And the cook, once the complaints started coming in, actually put some spice on the tongue and noticed that it made it numb. So the public health investigation began, and immediately the restaurant was closed pending the investigation. There were samples and leftovers that were collected for testing. There were a number of alerts that went out, which I'll outline in a similar timeline to what Dr. McVea showed. There were a series of multi-agency calls for public health management, both at our provincial Ontario level as well as at the national level. And this was coordinated under an existing provincial and national protocol, which calls for partners, specific partners, including the government ministries, as well as agencies of the government and public health units. And these calls were the focus of investigation updates and discussion, coordination of some of the activities, and as well as communications, for instance, to poison centers, for clinicians, to the public, et cetera. So as the investigation continued, of course, there was a visit to the distributor, which was actually licensed by the Canadian Food Inspection Agency, or the CFIA. And what they found at the distributor were two imported products with a similar label, with the galenga label, this Kaempferia galenga powder. There was no mixing at the distributor prior to distribution. And one of those products was later confirmed to contain aconitine, which had been used in the chicken dish. As I mentioned, the product had arrived with a similar label, and there was some follow-up at the Hong Kong supplier, which cited some issues with labeling as well. So the problem seemed to at least have originated from some of the supplier issues. The distributor at this point issued a voluntary recall. This was supported and fanned out by the CFIA, and there was follow-up at retailers and all points of distribution outside and inside of Ontario to follow up on this to ensure that the product was removed. So you see the timeline for Ontario here. The cases, the symptoms occurred on August 28th. The following day, very quickly, the restaurant was closed, and on August 30th, you can see that that the coordinated calls started. There was, in green, you can see the points of communication, a notice out to across public health agencies across Canada. On August 31st, there was testing done that tested positive for in the food. And just, one of the contrasts is that CFIA had actually developed, I believe, a method for testing for aconitine, perhaps since the BC episode. And so the testing actually was completed by CFIA in this case for the food samples. There was also product seizure from all the restaurants, from the restaurant, the importer, all the retailers and distributor involved, followed by more notices to the public, and the recall as this all happened. There's another blue point here on September 2nd for clinical testing, and in Ontario that occurred at the Centre for Forensic Sciences, so the provincial coroner's office. And in September 16th, all of those checks for product were completed. However, in October, there was another case that became identified, and that was through use of the product at home, I believe. So in Ontario, we really saw the value of a multi-agency coordinating framework. That framework is called the Foodborne Illness and Outbreak Response Protocol. There's an Ontario-specific version of that called ONFIORP. And following this instance, the Ontario Poison Centre was added to ONFIORP as a partner. But then the question became, well, what about for atypical foodborne events or even non-food events? And that's something that we are trying to still, work on and further improve in terms of those relationships and the chain of communication. Because in the absence of an existing framework, informal relationships and connections will be what we turn to. And at this point, in the Ontario situation, that is what we use in terms of this collaboration between Ontario Poison Centre and Public Health. Clinical and environmental testing, especially for these atypical agents, also a real big lesson learned in Ontario. And that includes interpretation of those tests and where those tests are going to be done, of course, as well as whether the tests are quantitative or qualitative. Those all bear on some of the decisions that can be taken as a result of the testing. So really important to have some of these testing resources worked out for atypical agents. Oversight and regulation of imported products, products such as these, was another lesson learned in terms of in what ways can we strengthen the regulatory framework. As well, communications and information sharing. I think this all leads to that first bullet of multi-agency coordination and the value of that venue for identifying who will speak on what, who needs to be spoken to, identifying the audiences that need to be spoken to. And so those were all some key lessons learned from the Ontario experience.
Good day. My name is Richard Wootton, and I am a team leader within Health Canada's Chemical Emergency Management and Toxicovigilance Division. I'm also a Collaboration Centre Manager for Toxicovigilance Canada. Before I speak, I would like to acknowledge and thank Dr. Wajid Ahmed for his contributions to the next section of this presentation. Unfortunately, because of an election has been called in the province of Ontario, he cannot speak publicly while the government is in caretaker mode. I thank him for joining the discussion today as an observer and his continued support working across disciplines and jurisdictions to advance toxicovigilance detection and management, as well as leading public health efforts in Ontario and across Canada. Toxicological events and mass poisoning events, including bioterrorism risks, is an evolving threat for all of us, and we must understand the increasing complexity of toxicological risk management. The world is evolving rapidly, and with the ongoing globalization, we have complex global food supply chains, increasing the risk of food contamination and outbreaks of foodborne illness. Furthermore, increased global interconnectivity has facilitated the trafficking of illicit drugs, leading to a rise in drug use and addiction. This poses significant public health challenges, including overdose deaths and the spread of infectious disease. The Aconite example presented today touches on many of the complexities, including the need for having a public health surveillance system for early detection of events, especially if these cases are popping up in different areas of the province or country. Our current systems are siloed. Any large-scale event will require integration between healthcare, public health, regulatory agencies, first responders, and law enforcement agencies to act in a timely manner. While we have an amazing team of toxicologists saving lives purely from a clinical perspective, but some of these toxicological events require public health investigation to rule out larger risks to health of the public. Public health investigation, including identifying toxin and removing the source, needs to be initiated as soon as it meets the criteria for risk to the health of the public. Furthermore, there is a need for linking healthcare and public health systems and stakeholders to allow data sharing and using data and informed interventions to determine and act on the broader public health risk. We need to look at how regulatory frameworks can be tweaked to enhance public health response in the future. The linkages between identifying the source of toxin, transporting the specimen to the appropriate laboratory for testing, For example, if there's a criminal element to the toxins, it has to follow specific transportation protocols to ensure chain of custody, which is an important consideration and must be a factor in as we timely detect and manage the response. As we are looking to strengthen our risk management and emergency management response capabilities, we need to start looking at the system level preparedness, including advanced biomonitoring techniques for early detection of toxins, since timing is really critical to rule out these threats. Data-driven decision-making will be a key to successful response. Leveraging toxicological databases, surveillance tools equipped with advanced analytics, and real-time monitoring systems will enhance detection and response efficiency. Integrating data systems allows for proactive risk assessment. We must foster and enable stakeholder engagement and data sharing to inform continuous improvement of policies and regulations to prevent threats. Strategic risk assessments, scenario planning, and emergency response simulations ensure we are ready for diverse toxicological challenges through ongoing monitoring and evaluation of our surveillance and response systems. We need to think about mobilizing resources in a timely manner, including antidotes and necessary medical supplies as needed. Transparency in crisis response is key to maintaining public trust. Clear, timely communication minimizes misinformation and panic, ensuring compliance with public health measures. In summary, toxicological risks are an evolving challenge, and we need ongoing evaluation and assessment of the risk and the required response capabilities. None of this can be done in silos. Partnerships and stakeholder engagement is key. In accordance with the World Health Organization guidelines for establishing a poison center, toxicovigilance comprises the detection and management of toxic exposure events of public health concern. The goal of toxicovigilance is to provide information for timely action to prevent, treat, reduce harm, and manage risks of toxic exposures. Understanding roles and responsibilities to address toxic risks are shared across many disciplines and jurisdictions. Toxicovigilance Canada was established as a network in 2018 to foster partnerships and collaboration, enhance common situational awareness, enable early warning and notifications, to foster targeted health threat monitoring, and to enable reach back to specialists. Toxicovigilance Canada lessons identified and learned from the Ontario and BC events. Need for strong linkages and timely information sharing between food safety and toxicovigilance partners, particularly with toxins and heavy metals. Prior to these Aconite events in British Columbia and Ontario, our program and Toxicovigilance Canada in general did not have well-established linkages to the food safety programs other than going through our Emergency Operations Centre. Following the events, we set up meetings with the Public Health Agency of Canada's Outbreak Management Division and the Canadian Food Inspection Agency to further discuss the role of poison centers and toxicology laboratories and the support that could be provided in timely detection, analysis, and providing expertise to assist Canada's foodborne illness outbreak response. This resulted in updates to both the food safety and toxicovigilance contact lists, notification procedures, and inclusion of specialists to joint situational assessments. These changes have translated into strong results, as we demonstrated in 2023 when a poison center first reported information associated with the United States cases of elevated lead levels linked to recalled applesauce, and the collaboration that occurred in Canada between food safety and toxicovigilance partners during this event. When a Canadian case associated with lead in applesauce did occur, due to cross-border shopping, provincial public health and Ministry of Health colleagues involved in the response were advised of the benefits of engaging their poison center if guidance was needed for clinical care. Also in 2023, a local public health unit required assistance for Aconite laboratory analysis, and thanks to enhanced linkages between partners, coordination of analysis conducted by the Canadian Food Inspection Agency was expedited, and the Toxicovigilance Canada Toxicology Laboratory Response Network was engaged for support, with a provincial toxicology laboratory confirming capacity and willingness to provide the support if it was required. These events further demonstrated the need to continue to develop our pan-Canadian Poison Center Surveillance Initiative, the Toxicology Laboratory Response Network, and all components of Toxicovigilance Canada. Our poison center surveillance system is nearing the production phase, and had it been available in 2022, timely pan-Canadian poison center data could have been more accessible to contribute to these multi-sectoral response efforts. By having a pan-Canadian surveillance application and by facilitating collaboration with all federal, provincial, and territorial partners, we can detect signals and monitor trends that may be weak at the state or provincial level, enable early detection, and support timely and effective coordinated interventions. There's a strong need for a network of networks spanning disciplines and jurisdictions. As we know, roles and responsibilities to address toxic risks are shared across several institutions, agencies from different sectors and jurisdictions. Following the Ontario event, the Ontario Poison Centre, the Office of the Chief Medical Officer of Health, Public Health Ontario, and Health Canada co-led a workshop to further build bridges between partners and to foster information sharing and collaboration between sectors. This face-to-face event was a catalyst for building trust and has supported us in working across disciplines and jurisdictions as we jointly respond to complex health events. These events also highlighted the need to consider how poison centers and toxicovigilance partners are integrated into jurisdictional level plans. I would say this is true for food safety as it is for chemical events, radiological emergencies, etc. Thank you for participating in the presentation today. We look forward to the questions and discussion. All presenters today are members of our Pan-Canadian Toxicovigilance Network. As a network, we are dedicated to working together to enhance our collective capabilities. We acknowledge the challenges we face and have shared some of those with you today. As Dr. Henry Breaux said in 1968, after having invented the child-resistant closure, poisonings are a preventable experience. And I believe that by working together across disciplines and jurisdictions, including at the international level, we have a real opportunity to save many lives. Thank you.
Thank you to our Canadian colleagues, Dr. Kim, Dr. McVea, Dr. Austin, and Dr. Wootton as well, and Dr. Ahmed for a really engaging presentation. And firstly, apologies to Dr. McVea for ascribing him to Ontario rather than to British Columbia in my introductions. I hope you'll forgive me for that error.
I'm sure Ontario would take him, though.
We're open for questions, and first up is from Dr. Kazzi in terms of clinical toxicology. I don't know if we have Dr. Austin might pick this up in terms of how is aconite suspected? Was it by EKG, ECG showing bidirectional tachycardia?
I'm not sure if Dr. Austin is still here, actually. I can comment for the BC experience. I don't know exactly what arrhythmias were noted. I think it was the full picture of what was happening, the oral numbness and the cardiac arrhythmias, as well as noting that other members of the family had not eaten that chicken prepared with this spice and had no symptoms whatsoever. So it was kind of the full spectrum of symptoms and the exposure.
Great, thank you, Dr. McVea. Next one, are there caches of antidotes located around the country or regionally to provide more rapid access and deployment, and or are there inventories of antidotes that are available?
Yeah, I can start that question. So I did provide in the link as well a link to the National Emergency Strategic Stockpile, which is managed by the Public Health Agency of Canada. And I can share that basically the National Emergency Strategic Stockpile is there to support provinces and territories when their supplies are exhausted. I can't go into specifics of what's deployed where. I can also say above and beyond the provincially run antidote registries, there is linkages between the provincial, territorial, and federal governments on those. And within Toxicovigilance Canada, we have actually established an antidote registry tool which has been used by, I think, 4 provinces at this time. And basically, it's a mechanism of, sort of the hospital pharmacies logging their inventories. And then, for example, the Quebec Poison Center would have access to that, and they could assist in the management of a patient by saying these antidotes are in proximity, and assist with that for rare events and also for those mass casualty events. Hope that responds to the question on antidotes.
Great, fantastic. Thank you. Question from Peter Uthoff. Is it surprising to the presenters that the only 2 individuals were implicated in BC?
Well, it's a good question. I think we don't have an excellent sense of how widely this product was distributed. If you consider the Ontario cluster, really there was one very large and very serious cluster. And then, as Dr. Kim pointed out, there was one other case that came months later. So it was a little, almost both provinces sort of had one really notable cluster. In Ontario, there was one other case. So it is surprising when you consider how potent this toxin is, and that it was distributed and people use it in food and whatnot. But for whatever reason, thankfully, it wasn't larger than these two clusters in each province. I don't know, Dr. Kim, if you want to add anything about what you would have expected in Ontario.
Yeah, it is a little surprising to me as well. But one of the things I recall is that the product actually had been imported in 2020 or so. So I think it may be, part of the reason I think might be that it's maybe just not an often used product, and that it's just not commonly reached for. Again, the restaurant had it because they had run out of the powder, and so they had run out to get something that was ultimately mislabeled. So I don't have a great explanation for it, but yeah, I just have that date in mind in terms of, it had been imported 2020 around there, and the clusters occurred in 2022.
Great, thank you. Just sort of a moderator's privilege. I'm intrigued. Was there any intelligence from colleagues in Hong Kong as to what the product was normally intended for?
Not that I'm aware of. You mean the Aconite, the actual mislabeled Aconite?
Yeah.
I believe that it's intended. I forget where I read this. I'm not sure if this is part of the debrief from this cluster, but there were some instructions I recall that it was to be cooked for 2 hours or something like that prior to consumption, and in the original for the actual product. And of course, it was mislabeled and used as sand ginger powder.
Okay, great, thank you.
I believe it is an herbal kind of a product used for kind of health purposes.
Okay, thank you. I think it's an observation. Just slightly jumped. An observation from Zena Schmidt. Thank you. I agree that we can prevent a lot of poisonings if we all work together. Countries working together and sharing information would help greatly. I think possibly one for you, Richard.
A global toxicovigilance network, love it. I think it's key. Completely agree.
Great, thank you. Then next one's anonymous. As the toxicovigilance surveillance system was only recently introduced, I'm paraphrasing here, how effective and timely was the communication between BC and Ontario provinces regarding the Aconite case?
So I can just comment about, I'll let Richard maybe comment about the surveillance system as it comes into effect. There are informal networks that are across the country between public health physicians and practitioners and poison centers and the medical directors of poison centers and whatnot. So it was, we were able to use to leverage those informal networks pretty well in the early days of the cluster investigation in Ontario. And our medical director of our poison center was in contact with the medical director of the Ontario Poison Center. Just through their, their colleagues, their friends, they actually saw this cluster in the news, I think, and immediately reached out and discussed. So those informal networks, they work well. Not as effective, obviously, as an official surveillance system and network. And so, Richard, if you want to add anything about that, or Dr. Kim, about your perspective of it.
That'd be great. So I think, like I said during the presentation, in 2022, our linkages with food safety specialists was not where it is today. It was weak. Now we have very strong relationships with, Canadian Food Inspection Agency, Outbreak Management Division within the Public Health Agency, and other partners. And when we started building the Canadian surveillance system for poison information to aggregate, analyze, interpret the poison center data, the first thing we did was we interviewed sort of all of the partners and said, okay, what do we need to achieve? And everybody basically said the same thing. We need timely data, we need quality trend data, and we need a strong community of practice that can take timely action. So basically this desire to build this Canadian surveillance system for poison information then informed the next piece of building a toxicovigilance network. And we built that on the Canadian Network for Public Health Intelligence. And we invite everyone in. If you're involved in detection and management of toxic exposure events, medical examiners, coroners, tox labs, the food safety specialists, we invite everybody in. I think the network's over 450 members at this point. And it's to enable, sort of that timely information sharing and collaboration. So we also do, sort of go to each jurisdiction. We do 2 jurisdictions per year to do these toxicovigilance workshops where we try to bring everyone together involved in detection and management of toxic exposure events and say, okay, how do we best work together? What are your concerns? And I think we've done those both in Ontario and BC, and I'm really grateful that we have, because some of the latest events, having an associate chief medical officer of health text you and say, hey, got this, what do you think? And being able to have that communication, just cutting through all of our red tape, is just unbelievable. And when you know each other and you trust each other, we can do so much more when we're doing it together. So long-winded response, but I think building the relationships, building the trust, sharing the information as quickly as we possibly can, having the relationship that enables you to say, I think I'm seeing something. I'm not 100% certain. If I don't know you, I'm not going to call you and say, Robie, I might see something. It could be nothing. But if we have a relationship, I'm willing to put myself out there. So I think so much of this is relationship building, so that we can do that timely information sharing. We need to have disciplines and jurisdictions working together. And, I'm really proud of the fact that our team has been able to embed epidemiologists within our poison centers. They're federal employees embedded within provincial health and hospital corporation poison centers to support the surveillance work, to support the centers, to work with the PT jurisdictions on their needs, and then at the pan-Canadian level. So long-winded spiel, but I think relationships and working together in the greater good is really important here. And I think, tying back to that previous question, so often we do this in domestic silo. And I'm guilty of this. When we had all the COVID-19 related exposures to bleach cleaners and sanitizers, a lot of conversations with JinHee, a lot of conversations with David, 450% increase in hand sanitizers. I'm working with the regulators on amendments to packaging and labeling requirements, public advisories, but not once did I share information at the international level. And that was part of the conversations on the Global Poison Center Network back in 2023 about this need to enhance this information sharing, not just domestically, but in the international level as well.
All right, thank you, Richard. I think you've touched on the question a bit more locally around sharing of information, collaboration with bordering US states and poison centers. Is there anything more specifically you want to add around that rather than more global?
Yeah, so that's obviously something we're very keen to support. We have incredible relationships with America's Poison Center, and we've had a long history of working with the Center for Disease Control. I know poison centers, obviously they have relationships with their local state partners. So I think at all levels, I should open the question to David and JinHee as well, because I know provincially there's a lot of collaboration with local states. So yeah, please go ahead.
Thanks, Richard. There's not a strong formal information sharing agreement or surveillance between ourselves and, say, Washington State, and it's a great opportunity there. But there are lots of informal connections and knowledge, and where we can reach out and discuss. And as Richard kind of commented there, say, hey, we're seeing this. Are you seeing something similar? But a lot of opportunity for more formal collaboration.
Right, thank you. Dr. Kim?
Yeah, I would agree with that. And I think in Ontario, as I mentioned in the presentation, I think we have the additional, limitation that the Poison Center is not formally connected with public health in our system. And so we're always working. And I think, we've worked together and referred to each other a lot informally. But I think there is an opportunity to make that more formal, more regular, and then also branch out from there to jurisdictions close by in the States as well. So again, a lot of informal connections, but not a lot of formal. And sometimes I think it's worth noting that I think sometimes more happens informally, right? More effective action takes place informally rather than through formal channels, and so we need that as well. But I think there's an opportunity to really formally build up some of those relationships as well.
And to start, just Robie, I know you got to control us here, but I think what JinHee said there, you want the informal, you need the informal, but there's serious value in the formal aspect as well, because we know many toxicovigilance, disciplines are struggling with resources, and globally it's known poison centers struggle. So by including these poison centers, the tox labs into sort of the plans at the provincial, territorial, state level, the federal level, it can assist with that resource component as well.
Yeah, and it links in very nicely to the next question, which touches upon is toxicovigilance more to establish trusted communication avenues between sectors and not use something like WhatsApp to communicate between partners?
Yes, so we have this Toxicovigilance Canada network, which is hosted on the Canadian Network for Public Health Intelligence. There's roughly about 100 surveillance and community of practice applications, health related, and that's owned and operated by the Public Health Agency of Canada. But the truth is, the network is not limited by one mechanism of communication. There's a lot of, sort of reaching out direct to emails, direct to people's cell numbers. It's one tool where if I wanted to get something out really quickly, David came to me with a see something, say something, BC seeing an increase in this in the toxic drug supply. I want everyone to see that at once. I'll go on there and post something. But, we don't limit it, whatever works to connect people.
Okay. And again, as your surveillance system comes online, how would it detect and alert on signals, especially in regard to small volume presentations? So small numbers of cases, does it have the power to detect those?
Yes, so there's two parts, and I should let David and JinHee jump in after I respond as well. We're working to build the indicator data-driven surveillance component, and we have epidemiologists working with the poison center specialists, the medical toxicologists, the specialists in poison information, and benefiting as well from partners such as Dr. Al Bronstein in the US, that's openly sharing some of the tools that they've built for detection, and we would welcome globally sharing information on how best to detect these signals. The other part that we are really supporting is the event-based. And this is really interesting because I think it can be done in any resource allocation, and it's enabling the specialists in the loop to, if you see something, you say something. So an example, we had a single case of a snack pouch with cartoon characters on it that contained hand sanitizer. And one of the specialists in poison information picked up the phone and said, hey, here's some pictures of a product. It was just involved in this pediatric poisoning. There's a product safety issue here. So we were able to reach over to the compliance enforcement branch and say, we got a single case. Here's the product. What do you think? And they were able to put in place a stop sale, stop distribution on a single case. That's hard to do. I mean, advanced analytics and tools can get us there, but I always kind of challenge our epidemiologists to say, can you beat the specialists in poison information? And that's a tall order, because they're managing these cases day in and day out, and they have a really good sense of this could be problematic. So if we can enable them to speak and share their evidence with those that can use it, it's going to be hard, even with advanced AI tools, to beat them.
Right. Anything to add, Doctors Kim or McVea? No.
Sorry, I would just add that I agree, especially for an outbreak or a cluster like the one we're talking about here. Your fastest thing for sure is going to be an astute poison center employee, a physician, somebody making that call immediately, talking and sharing with colleagues. There are going to be obviously delays in uploading, sharing, analyzing data, and at that point, for something like this, it's too late. So those two things go hand in hand.
Right. Next question, more on the regulatory front. Was there a system implemented or enforced after the incident to regulate the food retail market or the food species retail market?
Well, I would say nobody here is a food safety regulator, so I don't want to speak on behalf of the regulators within Canada, but I will just note, as Dr. Kim said in her presentation and said again in the Q&A here, this was a mislabeling incident, and both products were allowed, were permitted within Canada. One was a food product and one was a natural health product of some kind that's very toxic, but has some specific preparation steps, and they were mislabeled.
Yeah. And one thing I guess I will share, and JinHee and David, you were probably pulled into these as well, but both FACTS Outbreak Management Division, Canadian Food Inspection Agency, and provincial partners, there were numerous sort of after-action review and improvement plans and discussions that took place. I can't speak to some of the outcomes, but I do know, for example, the contact lists, the notification procedures between toxicovigilance and food safety specialists, and sort of the joint assessments that those were all sort of lessons identified, learned after this event. So there was definitely a very significant sort of after action review discussions between the regulators, public health, and other partners.
There's an observation around thanking you for a very interesting case study and showing the importance of cross-cutting work areas and multidisciplinary expertise. I think it requires feedback, just a welcome thanks. Next one's an interesting question from Mark Winter. Since this was imported years before the cluster was noted, could there have been fatalities that medical examiners would have missed? Again, crossing over into different regulatory areas, but don't know if anyone wants to comment on that one.
That's a very interesting question. I think the answer is possibly. I think that any fatality that was due to this kind of poisoning event would be so unusual that would have prompted an investigation. Coroners. If you had a healthy person who suddenly died unexpectedly, or a cluster of people who died unexpectedly after consuming a meal, those deaths would be flagged and investigated. So it's possible, but unlikely, I think, just because it would have been so unusual. And as soon as there would have been more than one person, it definitely would have triggered an investigation. I don't know, Dr. Kim, if you have any other thoughts.
Yeah, I mean, this is why, the story is so interesting in that, it's such a toxic product, and and there was product that was imported, with some time before noticing the recognition of the toxicity. So yeah, I agree with Dr. McVea. I'm not sure. I think there are mechanisms in place, and we've seen that at least in Ontario, just even recently, some situations where it was actually more kind of common run-of-the-mill sort of symptoms, still non-specific, that were identified as like quite unusual and requiring an investigation. And so in the case of Aconite, I feel that it would have been it would have stuck out to a lot of examiners. I'm not, I wasn't, involved clinically, but I do know from speaking with clinicians in Ontario that, there was, because of this cluster, when this cluster, was identified through their clinical presentation, it caused quite a bit of stir among clinicians because the arrhythmias were resistant to standard treatment. And so, it caused quite a bit of commotion and discussion among clinicians. And I just feel that it again, to David's point, that it probably would have been picked up just because of the toxicity.
But it's a great point about the connectivity between the medical examiners, the poison centers, the regulators, the public health, the wide spectrum involved in detection and management. And the more of us that are working together, the stronger we are.
From Tom, do you work with Public Health Agency Canada regarding potential biological exposures?
So definitely. So I belong to the Chemical Emergency Management Toxicovigilance Division. We're part of the Federal Health Portfolio, and under the Federal Health Portfolio, you have the Public Health Agency, the Canadian Food Inspection Agency, Public Health Agency, and Canadian Institutes for Health Information, etc. So we are quite tied to the Public Health Agency. We actually share an emergency operations center. And we leverage their emergency preparedness and response coordinators within each of the provinces and territories as some of our key linkages to key PT partners. So 100% well connected with them, as well as the level 4 lab in Canada and our partners in the National Microbiology Laboratory.
Thank you very much, Dr. Kim, Dr. McVea, and Dr. Wootton. Really excellent presentation. So I think we have finished with our case studies today, so we'll move on to just some closing remarks. So I'd like to express my thanks to all the speakers for really engaging case studies on their operational response between poison centres, engaging with public health, and also their emergency operations mechanisms as well. Just a few notes in terms of themes that have been picked up through the day. Discussions around decontamination protocols and approaches, especially for more vulnerable individuals, be they very young children, pediatrics as well. PPE, access to antidotes, communications between agencies, information sharing and data systems. We also had discussions around the roles and responsibilities of poison centres, both in supporting public communication and risk communication, but also in terms of the role of the poison centre being engaged as part of the emergency preparedness arrangements. I think picked up with the final presentation, the role of laboratory capability for rare and unusual toxins, and more broadly some biomonitoring capabilities as well, and then how we could use that data either quantitatively or qualitatively, and its interpretation alongside any environmental testing that is taking place in a timely manner as well. And finally, I think a number of presentations talk to how we can exercise and test our incident response capabilities in a multi-agency manner, bringing together all relevant partners within that as well. So I think there's some really interesting themes there that we're going to pick up in next Thursday's presentations, but also to open up a discussion a bit more in the town hall session on the 20th. I'd also like to thank all the delegates for your insightful questions and really engaging with the speakers as well. And for those in much later time zones, I don't think we had much of a drop off in numbers through the day. So thank you for remaining on the call and contributing. Overall, this was a wonderful first day of presentations, and we hope that you will join us again next Thursday for day 2. We have a very exciting lineup next week featuring 5 case studies presentations. And just a reminder that any of the unanswered Slido questions are going to be captured, and we will use those to inform the town hall session to be held on the 20th. So please join us again for an engaging live discussion session with all the speakers in the next 2 sessions. Thank you all very much for your time. And also thanks to our colleagues for hosting, running the tech. I think overall it was a fantastic method to engage across a large number of countries as well. Thank you.